webinar series. Today's webinar, Accreditations for Cancer Care, More Than Just CoC, is the first presentation in a two-part series on accreditations. The second part in the series is going to be titled Accreditations, Leveraging Your Data, and that is going to be presented at the second annual Priority Consult Workshop, September 25th through the 26th of this year in Indianapolis. And I really hope that you will mark your calendars for this event and keep your eyes open in the next week or two for an email invitation from us. We are working really hard to bring in really interesting speakers and discuss the most relevant topics for those in oncology. So I hope that you're able to plan to be with us for that one. Our speaker for this webinar, as well as the accreditations presentation at our workshop, is Cam Teams. She's the consulting principal and founding partner of Practice Advantage. She also was with us in April for a survivorship presentation webinar, so you may have seen her, joined her for that one. We did receive some questions during the registration process for today's webinar about accreditations, and Cam has tried to address those questions in her presentation. But if you do have any questions that persist or any additional questions that come to you while Cam is speaking today, please feel free to go to the questions section or questions feature in the GoToWebinar panel on your screen and enter them there, and then Cam will address those after the webinar today. All right, so with that, I'm going to go ahead and pass things off to Cam.
Okay, thank you, Rachel.
No problem.
Okay. All right, so I hope everyone can hear me clearly. If you do have any trouble hearing me, or I guess technological difficulties, you can also type that and let Rachel know so that she can address it. Okay, so the title of today's workshop is a result of a lot of feedback that I have been getting recently from several of my cancer center and breast center friends who say, you know, this is a tough place to be. My administrative team wants me to pursue every accreditation out there, but I'm only one person. I'm the oncology leader. Am I the one to oversee all those accreditations? Do I try to pass that down to my registrar? Who should do it? Which accreditations should we seek? You know, are we reinventing the wheel every time? And so because of those questions that I have you know, been hearing over the past probably you know, 12 to 24 months, I thought that this would be a great topic, and obviously many of you agreed since we had a good number of you sign up. Okay, so my goal today for, let me just make sure I can advance the, okay, wait, there we go. Okay, so my goal today, my roadmap for this, as I like to call it, for this webinar is for us to go through those things that I just mentioned. There are many accreditations and certifications that are relevant to oncology organizations. What are they? Which ones should be your accreditation or certification of choice, and why? Because you'll have to answer those questions likely to your leadership teams, which ones we should choose, and then the other questions that are also important are, you know, the return on investment. Many accreditations and certifications do have some cost associated with them, as well as the time cost to the staff who are overseeing those. Many of your senior leadership will look to you and say, well, what's the return on investment for these accreditations other than simply that we can put the logo on our website or on the patient-facing materials for our cancer center or breast center. And then we're going to talk a little bit about leveraging your work and the data that is required for many of these, and then some sample ideas about who should oversee those accreditations and some of what that workflow could look like. Okay, and of course, if there's anything else that you'd like me to talk about, you can just put that in the window. Okay. All right, so these are the accreditations and certifications that I'm going to talk about today that are the ones that I have chosen that have the most relevancy to an oncology program. And I have color-coded them based on their area. So before I get started, I do want to make clear that some of these are called these words are not used interchangeably, accreditation versus certification. Some of these are accreditations and some are certifications. And as we go through each one, I'll talk about which ones are accreditations versus certifications. So at the top of the list, of course, is the Commission on Cancer and its accreditation. The host organization is the American College of Surgeons. And that's at the top of our list because it is, of course, by the condition or the disease area of oncology, and it is for the entire cancer or oncology program. Then the three other accreditations or certifications underneath CoC that I have color-coded in pink are NAPBC, which is an accreditation, and QMBC, which is a certification, and the Advanced Certification in Disease-Specific Care for Breast Cancer, which is also a certification. So those three are specific to the tumor site of breast, and we're only going to talk about certifications specific to the tumor site of breast. For whatever reason, in the tumor site-specific areas, breast has really been the standard bearer of tumor site-specific certifications or accreditations. I feel sure that we will see other tumor site accreditations or certifications begin to surface, for example, in the area of lung or colorectal. But I'm going to only talk about breast for today. Then there are specialty area certifications that also fit well in your overall plans for accreditation or certification, and those are specialty college or society accreditations or certifications. Those are QOPI from ACOS, APEX, which is the new name of Astro's accreditation that instead of their parrot process, and the ACR's Breast Imaging Center of Excellence. So those are three that are specialty area accreditations that just naturally fit with your plans for accreditation or certification as a whole. Okay. All right. So let's talk. Those are the ones we're going to talk about, and now let's talk about why to accredit. Okay. So of course, in this day and age, the first layer answer is patients are pretty savvy in this day and age across the socioeconomic and demographic spectrum. Patients with breast cancer, specifically women, are savvier in their own health care. They're likely to seek out programs that have accreditations attached to their organization. We have, at some of our clients, we have done focus groups and specifically asked patients if that was something that made a difference in their decision making at different levels, either at simply choosing screening services like mammography or CT lung screening, or if it made a difference at the time of treatment decision making. And the majority of the people that we surveyed in those focus groups all said that it did make a difference if they saw or knew that advanced accreditation or certification was present by that either cancer center or tumor site program like breast. So we do know that it makes a difference. So it's important that you, if indeed those of you who are on the phone possess any of these accreditations or certifications now, that you don't hold that close to the vest. Be sure that you have that information on your website, that it is part of your social media, that it's on the information that gets in front of your patients. NAPBC does a lot of talking about how they want their accredited centers to be sure to share that accreditation with their patients, and several of the others do as well. So, so that is the very first layer, is we know that patients are making decisions based on that. And so as you are planning for increased market share, possessing those accreditations means something. Okay, the next layer that I think is we're seeing more and more evidence that it is a very important area for us to consider as we are looking at accreditation is reimbursement. So as Medicare, of course, continues to cut reimbursement, and as PQRS requirements are out there and more elements are going to be added, we know that reimbursement can be docked, as well as if those requirements are not met. And I think we'll see a lot of changes related to being able to, for you as the holder of those accreditations and certifications and the data that helps you secure those, the maintenance and the access to that data is going to help you as you address PQRS and as you address some of the other things that we're going to talk about. We also know that some payers are moving to per member per month. That is, for those of you who've been in healthcare a long time, that is a term that is now coming back to haunt us. And so WellPoint is the payer who has come out recently with per member per month, and they are paying a fee for adherence to guidelines for treatment to medical oncologists. And so that is going to require, again, data showing adherence to those guidelines, which is naturally going to intersect with your the data that you'll need to pull for accreditation and certification. Okay. Downstream revenue, of course, this is incredibly important. If patients are choosing you because of the existence of your accreditations or certifications, either on its own, on its face, or in compared to your competitor across the street or your large NCI competitor in the state, we know that it's not only going to bring patients into your cancer center or your breast center, but also significant downstream revenue, that important halo effect. And then finally, we think this is important. We have a lot of questions about, okay, well, now that we're accredited or certified, how do we use that in a good marketing effort? And you'll see that many other people, other than just me today during this, for example, I think the advisory board is talking about the resurgence of the term Center of Excellence and how each facility can begin to leverage that term associated with their internal accreditations or certifications. Center of Excellence as a phrase is not trademarked to any one specific organization, and so you as a facility are allowed to use it as a representation of what you're doing, either as at the cancer center level or at the tumor site level. And we think that you know, it makes it easier for the patient to understand. Okay, here's some, I've got one more here, our regulatory requirements. This is an example for the state of Michigan that they are waiving fees for locations that possess American College of Radiology accreditation for what was once their own state authorization or licensing efforts. So anytime we can save money or time, we'd like to see you be able to do that. Okay, all right, so again, which ones? I think that if you had to create a corral of accreditations to consider and to manage, these would be the ones that I would consider. And then we're going to talk about the, the different levels. Remember how I color-coded them? We're going to talk about those, and I would certainly break them up that way. And if you're going to pursue them, I would pursue them in broken out into those areas. Okay, which are, of course, condition. At the very minimum, I would, of course, recommend that you seek out Commission on Cancer, which most of you probably already have. And then next, I would identify your tumor site area accreditations or certifications, and then the corresponding specialty certifications. All right, so let's talk about, these are what I'm calling your level 2 certifications, all right? So Commission on Cancer is, utilizes National Quality Forum measures and needs access to your registry data. It does require some, the presence of a program leadership and conference, the presence of conference, either a general cancer conference or tumor site conference, and specifics associated with that conference related to volume of cases and its frequency and the multidisciplinary makeup of that conference. So I consider Commission on Cancer to be both quantitative and qualitative in its pursuit of information and its requirements. NAPBC does also, and you can see what I'm going for here is I'm going to begin to show you how there are duplications in much of the information that you're gathering across these accreditations or certifications that you can leverage and use to help you in your workflow and planning. So NAPBC also has NQF measures as part of it, which is a good thing, in their standard 2.12 and 2.13 for radiation oncology and medical oncology. It does require you to utilize your registry data to provide information to document certain standards, breast conservation rate, sentinel node biopsy, etc. And it also requires the presence of leadership, which often dovetails with the leadership that is in place specific for your Commission on Cancer in the form of a cancer conference. And often the breast program leadership is a subcommittee of your greater cancer committee. And then, of course, quantitative and qualitative as well, from my perspective, for NAPBC. For NQMBC, if you are considering NQMBC as part of your Level 2 planning, it also has NQF measures as part of its list of measures for its certification, and it also requires access to registry data. You certainly could have it. When I say registry data, that is, of course, the go-to location. It doesn't mean that that data could not exist if you have a separate database for your tumor site, your breast tumor site data. NQMBC does not require leadership or the presence of a breast conference, but of course it is important from my perspective that you have those things in place related to NQMBC so that you are passing that data through a group of qualified professionals who recognize the importance of this array of quantitative data. NQMBC is quantitative only. It is representative of the entire disease spectrum from screening through active treatment and post-adjuvant care, and has a total of 36 with its A's and B's measures, and is very comprehensive in its pursuit of quantitative data that represents your tumor site program. And then finally, the advanced certification in disease-specific care that is offered by the Joint Commission in the area of breast cancer. This is sometimes overlooked by many organizations, and I want to be sure to include it simply because of that. It is, much like NAPBC, quantitative and qualitative. It does require NQF measures. If you have chosen those as the measures, during that certification process, you have the opportunity to choose measures that you will both measure and report. And of course, I recommend choose measures that you already are tracking for your other accreditations that you have in place or are pursuing. Those measures for advanced certification in disease would also come from the registry likely, or a separate data set. There is no requirement for leadership or a conference except as it relates to your program standards, and we'll talk more about that. But so quantitative and qualitative there as it relates to the advanced certification in disease. Okay, all right. So if you were planning, then of course I would take these as your taking the bigger corral and whittling it down. I would take this group as your first group to pursue. Commission on Cancer first, and then NAPBC and QMBC and advanced certification in disease-specific care, and leveraging the three areas, accreditation and certification areas in pink for you know, the cross-sectioning of data that they require. Okay. Ooh, I'm too fast. All right, so then let's talk a little bit about the specialty accreditations also. These are specific to the multi-specialties that are represented in your programs, either your larger cancer program or your tumor site-specific programs. So, and the presence of these, while not required currently by any of the other accreditations or certifications, they certainly do ask if this is in place, and I feel sure that in the years to come, we may see the evolution of these specialty accreditations to be required, simply because they demonstrate specialty commitment to your program. So I won't go over all of these, but these are in depth. But you can see here I just put in the far right column what is required and what is measured as part of these specialty accreditations. So and you can see here there's not a lot of overlap, if any, in these three specific specialty accreditations. So, and they do require a fair amount of heavy lifting by either your owned or under arrangement or partner medical oncology, radiation oncology, or radiology practices. Okay. All right, I want to just talk for a minute about these national quality forum measures that are also your CoC measures, and then you'll also see that these cross-function into NAPBC and QMBC as well as PQRS. Okay, so again, once you're pulling this data, you can see that it has the ability to be utilized and leveraged across the accreditations or certifications. Okay, so NQF measure 219 is also 219, 559. 220, 223, and 225 are the NQF measures. 219, 559, and 220 are for breast. 223 and 225 are for colon. And then you'll notice that 220 also cross-functions here. I have noted on the screen it cross-functions into the PQRS Oncology Measure Group, and it is number 71. Okay, so whoever is gathering that data, and often I hear from my client contacts, friends, etc. It's a right-hand, left-hand problem. Sometimes the oncology measures that are for PQRI are being overseen by somebody on the revenue side. Decision support side, as opposed to that cross-functioning over to the oncology service line and involving the people who have close knowledge of the data that makes up this measure, which would be, of course, the registrar and the oncology team, and in this case could also be the breast program leadership, who would be reviewing NQF number 220 as part of both their CP3R data that is coming down to the breast program leadership, but as well as their ongoing review for their NAPBC accreditation or certification. Okay, so these are these are NQF measures that have a number attached to them, and then I've just listed the other NQF measures here on the right-hand side. Okay. All right, so let's talk about this. This is what you came for, probably. This is that, that leverageability, that, okay, what am I doing for one that I could be doing for the other, that, helps me as, if of the people who are on the phone, many of you are oncology leaders, registrars, or trying to figure out how do you manage all of these accreditations and certifications, again, as I said, without reinventing the wheel. So this is a grid that we created to help some of our clients just have it in a big picture of how the they can have some of this work cross-function. Okay, so you can see here that so for the Commission on Cancer and its CP3R data, these are the 3 NQF measures, 219, 559, and 220, which are the ones that will look familiar to you from up here. All right, so those CP3R measures that come out of the National Cancer Database, those also cross-function with NAPBC, and 219 cross-functions with a standard 2.12. 559 cross-functions with 213, 220 also with 213. And the information that is looked at during the site survey and the chart audit section of your site visit. The site surveyor is looking for the adherence to those measures from a medical oncology and radiation oncology standpoint as they are reviewing records on site as part of their site survey. And then, of course, these closely align with NQMBC measures 25, A and B, 24, A and B, and 26 A and B. And then, as I mentioned, the certification in disease-specific care, it also has the ability or asks for you to have performance measurement. And I, of course, advocate if you are already measuring performance with CP3R, with NAPBC, with NQMBC, that you choose those measures and leverage those across to your Joint Commission disease-specific certification. Okay, so hopefully this is a good graphic that helps you visualize. Now, it's only, of course, 3 of the areas. For NAPBC, of course, you have 6 chapters of qualitative and quantitative accreditation that you have to manage. With NQMBC, the total of 36 measures, 31 measures, but 36 with their A's and B's. And then, of course, the requirements for Joint Commission. But I think that something is better than nothing, and I think once you begin to see this cross-functionality, then you won't be repeating yourself. Okay, so let's move down a line. The leadership requirements for NAPBC and the interdisciplinary breast conference, clinical management, and the interdisciplinary patient management requirement, as well as quality improvement and standards 6.1 and 6.2, all of those cross-function directly over to the Joint Commission's disease-specific care certification. All of those will directly correspond with how you'll document your program management, your program standards, your performance measurement, etc. So much of that will easily come across. So if you've been through NAPBC and its accreditation, I would do it first before you pursue Joint Commission and the disease certification in breast cancer, because so much of what you have to do there can cross-function. With NQMBC, the other measures outside of those 3 NQF measures, the breast imaging measures, pathology timeliness, patient satisfaction, etc., although those do not cross-function across by name across the other accreditations, certifications, I think that I think that you'll be able to leverage those unto themselves as we talk about some of the return on investment at the end of this this webinar. Okay, and then finally, there is the leverage of the quality improvement standards for NAPBC 6.1 and 6.2, and the performance measurements that are required for Joint Commission. Okay. 6.2 is still pending, of course. Okay, let's talk about some of this return on investment. Okay, so for me, the first one is uncovering your hidden benefits. And we started this webinar talking about how, I heard from many of our focus groups that indeed accreditation made a difference. But I think that although focus groups are great and their data can be leveraged, I think that quantitative leverage is important. And so I recommend that you do that if you do not already utilize Press Ganey. I think that this is a great way to add some Press Ganey questions. I also think it's a great way for you to leverage your social media, have your marketing team be sure that you have questions out on Facebook that can survey your patients who are social media loyal to your organization to understand if accreditation or certification made an impact. And then, of course, the utilization of electronic surveys like SurveyMonkey to ask those questions of both of patients at all points in the patient continuum. And then that quantitative data will speak for itself as you go back and think about adding additional certifications. Okay, other hidden benefits. Many insurers may reduce the risk rating for those that have more than one Joint Commission accreditation or certification. We are hearing that. We called a couple of the Joint Commission clients of ours who also have a disease-specific certification and asked, did you request that your risk rating be lowered? A couple of them have said, well, we're self-insured, and so it was part of our internal determination. And many of them said that it is clearly a discussion point. While it may not be enumerated by their liability carriers, it is certainly determined in their risk rating as they are reviewed by those liability carriers. But I think it should be so much more than that. I think it should be a proactive ask of the liability carriers to take into account your accreditations and certifications that are in place. They're there for a reason. They document your program standards. They document your commitment to quality, and which, of course, goes back to the main tenet of safety and risk management. So I think it needs to be a proactive step. Okay, then of course this is the most important potential hidden benefit, and that is to look at your data and then leverage that data for some very specific payer conversations and negotiations that would lead to carve out fee schedules that represent what you're doing that is different, and that brings to that payer a higher quality of care for their members. This graphic here is just an example of some leverage of the availability of data that can happen back to a payer. Remember how we talked about at the beginning that many of the accreditations and certifications have quantitative data that is required of them. And that quantitative data that you are spending your valuable time garnering should be used at the table when you are looking to your largest payers to provide you with unique reimbursement associated with the quality of your program, either your greater cancer program and its comparison in the aggregate to other organizations using your CP3R data, or if you are only talking about your breast program and you are looking at your data compared in the aggregate to other centers. That is a fantastic offering of NQMBC, that you can look at your data that you have entered compared to centers that have similar volume, centers that have similar components, as well as all of the centers that participate in the NQMBC program. That is amazing data, as well as how you compare in the percentile. And I hate to see that data go to waste, to only be in a report that is discussed at the cancer committee or at the breast program leadership level, and not to be leveraged outside of your organization to bring increased revenue associated with that pursuit and receipt of quality. Okay, all right, so let's talk a little bit about, this was, again, another question that came ahead of time. How do I manage all of these accreditations and, the data associated with those, and, as an oncology leader, as a physician liaison for the larger cancer program, etc. How do I manage that? So hopefully this graphic helps you visualize that. And we'll talk more about this at the program in Indianapolis. We're going to talk more about the workflow as well as the data leverage, and we're going to go through some specific examples of the data based on the level 2 and level 3 accreditations and certifications, and what that data actually looks like, and how you can pull that data out of your registry or database, and then how to leverage it for managed care negotiation, or back to your liability carrier. Okay, so this is just one of the ways that we recommend that you manage it from a workflow perspective. So we think that there of course needs to be an accreditation oversight leader. This can be a decision support person, but most likely this is the oncology leader. This is the person who has the landscape view of not just the oncology program, but has the landscape view of all the tumor site programs as well. And most of the time that is the oncology leader, the service line VP for the facility, who has that view. And so we recommend that you create a group executive team that brings together these key 5 people. A decision support analyst or staff member who can pull data that is not necessarily registry data, but other data points that quantitatively are needed back at your level 2 or level 3 accreditation pursuits. Okay, and that's going to come out of your, most likely that's going to come out of your decision support software related to billing, okay, business objects, that kind of thing. And then at the table, I love to see both your medical oncology practice lead and your medical oncology liaison physician. They who represent what's happening from a medical oncology standpoint, both in the practice itself as well as from an infusion standpoint, whether that infusion is hospital-based or in the practice-based. And that, of course, then leads to the QOPI certification. Then, of course, your radiation oncology practice lead, that's the operations person who has access to the quality information that is required to support your Astro Apex accreditation if you choose that. Or if you do not choose accreditation, then for NAPBC, for example, you do have to document your quality initiative. And so it is, in our experience, it takes both the operational person and the physician to be able to oversee the documentation of that quality initiative from a radiation oncology standpoint for the greater cancer program as well as for the tumor site. And then, of course, your registrar and the cancer liaison physician for Commission on Cancer, their presence at this table is incredibly important to be able to focus on the highest level accreditation and the downstream effects as well as the upstream effects associated with the Commission on Cancer accreditation. That is incredibly important that they have a view of what is happening from a tumor site perspective and from a specialty perspective. And then, of course, the breast program lead and the breast liaison physician, who typically is the head of the breast program leadership. Then usually these three accreditations, the American College of Radiology Breast Imaging Center of Excellence, NAPBC, and QMBC fall under those two leaders. So this is what that group executive team typically looks like. And then you see that I have the Joint Commission logo here to the left as it relates to the oversight leader, because the Joint Commission disease certification does pull information across these, and in many cases there is a Joint Commission staff member whose main job it is to oversee Joint Commission. Typically that person also needs to be at the table. It could be the same person, or it could be a separate person who joins the group executive team, if that makes sense. Okay? And then, of course, I just want to mention again, this decision support person is incredibly important, because this group that is going to be getting together, strategically planning which accreditations and certifications to seek, and the timeline associated with those, leveraging the information across those accreditations and certifications, and the data that is going to be leveraged across them. The person who, you need an analyst or a decision support person who is managing those data sets. And in some cases it is as rudimentary as managing all the Excel spreadsheets that came out of the registry and the breast database and all the different locations, as well as business objects or whatever reporting software is used out of the larger hospital system, and putting all of those data sets together to be able to be reviewed by this team. So somebody who is savvy and who understands the etiology of each one of those data sets is incredibly important. Okay, all right. All right, we have 10 minutes here at the end. I know I went through that very quickly, but like I said, we'll keep going with this topic in Indianapolis, but I wanted to start the process with the high-level view of all of the accreditations, which ones, and how to leverage them all across each other. Okay, so any questions, Rachel?
So far, all that I see are questions about whether or not we'll send out the presentation,
Okay.
send out the slides to everyone, and I will send them to anyone who's submitted that question. You can also email Cam, or you can email education@priorityconsult.com to request that the presentation be sent to you. We might want to wait just a second here to see if anybody does have any questions that they want to submit.
Okay, I know it's a lot of information.
I know, it is a lot.
50 minutes.
Yes.
We'll give everybody a minute to type. If you have specific, I've put in here, we have an organization, a sub-organization called Oncology. If you have any specific questions about accreditation of those individual accreditations or certifications that I mentioned, of course, please go to those organizations individually, but you also are more than welcome to email us, and we'll try to answer your questions the best that we can, or send you back to that individual accreditation or certification. And our contacts there, we call them all the time to ask questions to make sure that we are representing them well as we support our clients in their efforts toward accreditation and certification.
Okay, I did have a question that just came over. The question is, do you know how successful centers have been at negotiating better rates? Okay, well, my answer is yes. We've been part of 3 efforts. There haven't been that many that we've been part of, but we've been part of 3 efforts where we have been across the table with the medical director of a large payer, and we specifically, I'll tout NQMBC here. We specifically used the NQMBC data and its aggregate information to show the efforts of those organizations, and it did result in a fee schedule increase. Now, we of course hope that that increase will, continue to grow. But we think that the fact that we got the payers to sit down and even have a dialogue about it was a great first step. We weren't expecting, fee schedule updates, to be, twice the amount. But we were glad to see a small uptick. We didn't get what we asked for. I'm going to be totally honest about that. But we did get something that didn't make us feel like that we walked away empty-handed. So, and as many of you know from your history in healthcare, the payers themselves are not the ones who have the data in front of them. And so it is incredibly helpful for you to be able to have that data in front of you, document it, and to show them that you are both monitoring that data yourself, as well as what those results have been, in its trend. So you show them when you began looking at the data and how you have changed it over time. For example, time from diagnostic mammogram to first tissue sampling, and those sorts of things make are compelling data points for payers who know that timing has everything to do with their own internal costs, so to be able to provide them with that data sometimes leaves them a little bit flat-footed, and does cause them to to take you seriously and to be willing to, as long as you can substantiate the data ongoing to them, and that you can substantiate those quality levels at an ongoing rate,
then they are happy to increase the revenue there. But of course, you open yourself up to having to continue to provide the payer with that data to substantiate that increased reimbursement. That, of course, goes back to many of your questions related to workflow. But if you have that group in place, then it makes total sense to be able to, as that group is looking at your accreditation or certification data, and it has a timeline attached to it related to either receiving that accreditation or certification and then ongoing maintenance. So once you've received NQMBC, NAPBC, CoC, of course, and Joint Commission disease-specific, though many of them have recertification or time periods when that data needs to be resubmitted, and so it's important that your workflow group that you establish meets in tandem with that timeline as well. And then hopefully you can then leverage that data out to your own state Blue Cross and Blue Shield. Those are typically the organizations that are open to it, or state-specific payers. And then you're already reviewing the data for those organizations, and then it makes it easy enough to maintain your promise of information back to the payer who agreed to a carve-out contract.
Okay. The next question that we've received is, did you find that oversight of all mentioned accreditations were more successful if oversight was done by one person, or should it be disseminated, which I guess means like more of a team approach?
Yeah, I think that if it is a team approach, that's important, but I do think that it needs to be one high-level person. I don't think that it can be without that high-level person, because they need to be able to see everything across the facility's landscape. Otherwise, the person who's overseeing NAPBC or NQMBC is off doing their thing, and it's a right hand not knowing what the left hand is doing. And then the people who are doing CoC or that are doing QOPI, etc., they're not talking amongst themselves. So I think that one person facilitating the group is incredibly important. I don't think that one person can oversee all of the accreditations, just in case that was coming next. I think that is, if you're looking at my level 2 list, CoC, NAPBC, NQMBC, and Joint Commission disease-specific, I think that is incredibly hard for one person to oversee all of those who also has another position in the organization, okay, like your oncology leader or your registrar. Now, it could be that if you can document your ROI, you can justify one FTE, and that's perfect. Then I think that is incredibly reasonable for there to be an FTE dedicated to accreditation, and I think we'll be seeing that more and more.
Okay, that was the last question, so I think
okay.
I think we'll just wind things down for today. Thank you so much, Cam. I really appreciate you giving this webinar and also agreeing to be with us in Indianapolis, September 25th and 26th. And thank you all for attending. I hope that you got a lot of benefit out of this. Again, if you had put a question in about receiving the slides, you don't have to send a separate email. I'll see your question there, and I will send you the slides a few minutes after we end this now. So, all right. Thanks again, Kim.
Mm-hmm.
Okay. Bye-bye.